I'm Kwee Yong. I'm a haematologist at University College London in the UK, and I have a special interest in treating patients with multiple myeloma. Today we are in sunny Mandelieu in France at the ESH meeting for multiple myeloma, and we have heard about all the new treatments and agents and strategies that are becoming available for patients, particularly at diagnosis. But I want to talk particularly about how we can treat patients who are not eligible for stem cell transplantation when they don't have access to new drugs and when they don't have access to clinical trials. So our two backbone treatments are still VMP, Velcade, melphalan and prednisolone, and RD, Revlimid and dexamethasone. But it's many years now since those seminal trials were carried out and reported, and of course we have learned a great deal about how to optimize the use of these regimens. The VMP regimen, of course, has been optimized through the years with weekly scheduling of Velcade and also subcutaneous delivery, which has much reduced the incidence of peripheral neuropathy, toxicity and discontinuations because of adverse events. And so all the upfront Velcade regimens today utilize weekly Velcade, and there have been studies comparing, for instance, a doublet with Velcade and prednisolone against the VMP or even VTD, which is Velcade, thalidomide and dexamethasone. And I think summing up all these different trials with different combinations of Velcade, looking at doublets and triplets, the bottom line is that many of these are well tolerated when used with the weekly Velcade regimen. And in particularly, one of the strategies I particularly like is the use of a triplet regimen upfront for a limited duration, say 6 or 9 cycles, and then followed by Velcade maintenance at fortnightly doses, or even an attenuated schedule of, say, Velcade and thalidomide maintenance. And the results of these strategies are really very good because they allow a more intensive treatment in the first phase and then a more less intensive attenuated regimen which is tolerable, and so a higher cumulative dose of Velcade can be delivered. And we do know that increased cumulative doses dosing of Velcade actually correlates to better outcomes. So what about RD? What about lenalidomide and dexamethasone? That has also been trialed against triplets, like in combination with melphalan or with cyclophosphamide, like the UK Myeloma 11 study with CRDA. And generally these studies show that the triplets are deliverable. Probably in the frail patients, doublets yield better results because they give rise to less toxicity, and so less patients come off treatment. But of course there is also the option of combining both Velcade and lenalidomide approaches, and this has been done by the Spanish group very nicely with a sequential 9 cycles of VMP followed by 9 cycles of RD versus alternating cycles. And although both arms of the study were equivalent, what the study does show us is that when used optimally, these regimens, when combined, gave a very impressive PFS of 32 months and an overall survival approaching 5 years. So that's just very impressive results. The MRC11 study had a different approach where they treated patients with an IMiD, either thalidomide or lenalidomide, and then for patients achieving less than a VGPR, those patients went on to be randomized to a Velcade regimen. So this is a kind of two-step stratified approach, with switching to an alternate regimen to deepen response in patients with a suboptimal response, but of course sparing patients the potential toxicity of having all agents up front at once. So finally, of course, the VRD regimen has been used in this patient group. There was a nice publication from the Boston group, I think, and this was an attenuated VRD regimen in a small group of patients, and this produced an impressive median PFS of around 3 years. So there are many ways in which we can combine and use these two backbones, VMP and RD, to optimize outcomes in our non-transplant eligible patients, even if we don't have access to all the new drugs and to clinical trials.